Tonight I want to introduce Dr. Terrence Early and Marta, who you've all met before. They're going to be talking about the current evidence for the efficacy and safety of ketamine treatment for treatment-resistant depression. And I sent you out their bios, a little bit about them, so I'm not going to read all of this to you again, but I'll have them introduce themselves as right before they talk. So please welcome Marta.
My name is Dr. Marta. A little background on my academics. I majored in molecular biology at UC Santa Cruz. From there, I went to medical school at Chicago Medical School, Rosalind Franklin University in Chicago. I did a psychiatry residency at UCLA's Sepulveda VA program. Got a lot of experience with PTSD there, and got involved in some research, including this project that I'm about to present here. Primarily, my research interests are psychedelics, club drugs, safety, and risks associated with them, potential therapeutic uses, and ketamine is part of that research. Now in clinical practice in Los Angeles and Santa Barbara. I also do one day in a homeless program called Step Up, and still continue to try to do as much research as I can get involved in. And next year will be the PI for the Los Angeles site of the phase 3 trials for MDMA-assisted psychotherapy for PTSD with MAPS. Thank you all for having me here. This is very exciting for me. I've been coming here whenever I can, and I really enjoy the community here. All right, so get right into it. Ketamine and depression. Some disclosures: I don't have anything to disclose. I'm not on payrolls with anything at this point. Not receiving funding from anything at all. A lot of the data here is from a paper that myself and my colleagues, Dr. Wes Ryan and Dr. Ralph Cook, put together in 2014, was published in the International Journal of Transpersonal Studies. Recently updated, submitted for a MAPS publication to come out this year or next year. That is a larger look at the current state of ketamine and therapeutic uses. So, with regard to depression, kind of where we are right now, all of the medication treatments have been primarily focused on the monoamine system, meaning the dopamine neurotransmitter system, primarily the serotonin neurotransmitter system, and a little bit with the norepinephrine, epinephrine neurotransmitters. And a large study called STAR-D was done in the 2000s, and looking at kind of the success and the differential success between different medications for depression, that showed that despite multiple trials, about 35% of patients seeking treatment remain symptomatic even after several treatments. Just a couple of key terms: response in medical literature, which is a lot of what I'll be presenting on, is defined as at least a 50% reduction in a validated measure of depressive symptoms. Common ones are the MADRS and the BEC. And remission is considered at least a 50% reduction in score, and also a score below a particular threshold for those scales that's considered basically free of a diagnosis of depression or considered well. One problem with all of the treatments that we have developed so far, or nearly all of them, I should say, the monoamine system targeting medications, one issue is that even after starting, if you have a medication that's going to work for somebody, they won't see that relief for several weeks. leading to a very tricky window. If the first treatment doesn't work, this can drag on and requires a lot of patience on the part of individuals. So why is ketamine so exciting? Ketamine is introducing psychiatrists and psychiatric researchers and psychopharmacologists to an entirely new potential system to explore. There's been a lot of congeners of ketamine that have been developed by drug companies who are sort of trying to find alternative molecules working on the same neurotransmitter system, same molecular system that ketamine is, and trying to figure out why ketamine works. And it's sort of like a whole new paradigm for treatment of depression. Ketamine also has been one thing that's really exciting about ketamine is that pretty much all the studies that we'll be talking about or that I'll be reviewing are for people who have already been considered treatment resistant, meaning they've already tried several things. This isn't even, the results that we'll see are not for people who've never tried any other medications yet. It's people who are really difficult to treat. Another big advantage is the rapid response. Oftentimes, as you'll see, people have a response within hours and lasting several days from a single treatment, for example. There's also evidence that there's a reduction in suicidality, and we'll talk a little bit about that. And yeah, obviously, a whole new hope for people suffering from depression. So what we wanted to do, my group, was explore all of the existing evidence for safety and efficacy with a single treatment of ketamine, typically at this regimen, 0.5 milligram per kilogram, IV over 40 minutes. We also wanted to see if there have been any successful strategies for prolonging the effects. One criticism or one question that remains popular in the literature and in conversations is this concern over the fact that the majority of the larger studies have been a single dose showing a short duration of effect, and that effect not being long-lasting. We also wanted to see if there is evidence for other routes of administration, because IV is rather cumbersome, it's very expensive. From a clinical perspective, it really limits the accessibility to a large number of people who are dealing with treatment-resistant depression. Talk a little bit about the isomers of ketamine and any evidence for there being one isomer being better than the other, and we'll talk about what isomers are. Also, we look at the evidence for suicidality and talk about what we know so far regarding risks and adverse effects of ketamine. What we did was search PubMed for the key phrase ketamine depression, which yielded 1,274 studies, all of which we reviewed at least the abstracts for to see if they were going to be appropriate for us. We wanted to look primarily at studies involving humans clinically. We weren't as interested in some of the minutiae regarding biomarkers, which is an important thing to look at, but outside of the scope of what we'll talk about and what we decided to review. Also, the neurocognitive effects, neuroimaging correlates, those are popular, especially with the biological model of depression. We ended up reading and reviewing in detail a total of 77 publications, majority of them using IV ketamine. Very few people, there's not a lot of data in general about these isomers that exist, and we also really wanted to look at the difference between unipolar depression and bipolar depression because they're two different monsters with very different responses and different concerns that you have to worry about in treating them. Again, the response is defined as a 50% reduction. So, this is one of my favorite things we've ever created. This is a compilation of all of the data that for a single dose of ketamine, for an IV infusion of 0.5 milligram per kilogram, and the blue is the response rates with ketamine. These are randomized controlled trials, so side by side, approximately half of people enrolled in the study receive ketamine, about half of them receive saline, and this is compiling all of those types of studies. I have the specific numbers, like the ends involved for each of the data points if anybody wants more detail about that. But as you can see, 25 to 30% of people respond within 4 hours. 50% reduction in depression is what that's showing. Peaking at about 2 days and often lasting to 7 days. Some people much, much longer. With saline, obviously not so impressive outcome, which is to be expected. And this was really exciting to see. I hadn't seen it put in this visual format. This is the evidence from open label investigations, meaning that the participants in the study were aware that they were receiving ketamine. There wasn't some possibility that they would receive a placebo or saline. And this data it pretty much correlates with the randomized control trial data, showing efficacy very rapidly in about a third of the patients, and more than half of patients achieving a response within the first couple of days, and response lasting a few days for the majority of those people who did respond. Those were for unipolar patients with treatment-resistant depression, people who have failed several trials of approved treatments for depression. This is for bipolar depression, which has been notoriously difficult to treat clinically, and the response rates here are just as impressive. More than half of people responding to a single dose very rapidly, and that response lasting for several days in a single dose in the majority of cases. There's a typo on here. Ketamine is the blue bars, saline is the red bars. Now, one idea for prolonging the benefits that we see with the single dose of IV infusion of ketamine is repeat dosing of ketamine. It's almost a bizarre criticism that a single dose doesn't provide lasting effects, because nothing that has been proposed for nothing that's been proposed for depression has been expected to have prolonged effects from a single administration. No psychotherapy, no medications, ECT, nothing. In fact, nothing has had as robust a response from a single administration as ketamine has. So this is data compiled from several studies that attempted to prolong the effect, which showed that more or less, as long as people were receiving infusions, typically the regimen was twice weekly. Some studies were 3 times weekly. But the benefit was prolonged until discontinuation. There's after the final infusion there, then in fact with the repeat dosing you can see people seem to go longer. More people seem to still be benefiting at 6 or 7 days, which is where it kind of dropped off with the single infusion. And about half of people who responded were still responding as much as 3 weeks later, 4 weeks later, with no further treatments at that point. So, next to the IV route of administration, the majority of, I'd say the next most popular route of administration that people have attempted and reported on is intramuscular administration. Total of 31 patients, one randomized control trial, one open label investigation, and you can see the details here, but more or less intramuscular administration had similar outcomes as IV administration, suggesting that it might not be necessary to involve the cumbersome strategy of IV administration of the drug. A couple of really great studies have been done with intranasal ketamine, which is typically in like a saline solution that people spray. One really well done randomized control trial on par with some of the IV studies that were done found similar response rates, 44% rate, 44% response 2 days after even a single dose. And a trial in adolescents with bipolar depression using 30 to 120 milligrams found similar response as well. And that was also a longer term study with repeat dosing, once weekly or twice weekly. Other routes of administration that have been looked at, though not studied quite as well, have basically repeated what intranasal and intramuscular have shown, which is that it doesn't seem to, IV doesn't seem to have any like magical properties to it. There isn't a reason that IV administration is superior in any way. In fact, there's no evidence that it is. So why do we care about the alternate routes of administration? So a little bit of history of how IV became the popular route of administration. The first time that a psychiatrist proposed studying ketamine for depression, when you go to an institutional review board, which is sort of like an ethics panel at whatever institute that you're doing research at, and that all studies have to be approved by in human subjects, one thing that they like to see is as little difference from what's been established safe as possible. And so when they were looking to try ketamine for depression, they basically consulted with anesthesiology, who had been using it for anesthesia for 40 years at that point, 30 years, 40 years, and anesthesia administers it by IV. So to propose to an ethics board, not only trying to give this drug for a new indication, but also changing the way that it's administered, is more than they like to see. So since then, as these kinds of accumulative comparisons that we did can't be done if there is too much difference in the protocols that are used. So for the purpose of being able to compile a large body of data to show this is helpful, basically everyone after that also adopted the IV model. So it's more of like a matter of fact and historical appendage that that the majority of the research has been done with IV as opposed to these other routes of administration. And from a clinical perspective, this is hugely important because using an IV requires, it's much more invasive. You're going right into somebody's bloodstream, which is basically leapfrogging a lot of your protective barriers from infection. You're not supposed to have access directly to your bloodstream. And so the other routes of administration may not only be safer from that perspective, it also offers a much wider opportunity for distribution due to lower costs and greater availability. So this question of S versus R ketamine basically has to do with the arrangement of molecules in what appear to be the same the same overall molecule, but it's sort of like right-handed versus left-handed. They'll be mirror images of each other, but if you try to superimpose them, they're not exactly the same. So there are differences between the S isomer, that is what they call it, and the R isomer, and there's been a lot of interest in finding out if one or the other is better for the purpose of depression. And there's even a drug company that's trying to, I believe they're trying to patent S-ketamine as a novel molecule, so they can use that for depression, because there's not much financial incentive to do the really expensive studies required to bring this to like FDA approval. For example, the phase 3 trials for PTSD are somewhere in the tens of millions that MAPS is trying to raise, and that's on like a shoestring community effort kind of budget. So basically, there's very little data on this matter. The S-ketamine has been studied sometimes directly versus the racemic mixture. S-ketamine seems to be twice as potent, so like 1/4 milligram per kilogram seems to be similar to a 0.5 milligram per kilogram of racemic. So far, there's been no studies that we found with just R-ketamine in human subjects. And one of the claims for developing S-ketamine is that there was originally some evidence or some hope that S-ketamine did not have these unwanted psychotomimetic and dissociative side effects. However, there have been subsequent studies that have shown that S-ketamine delivered a strong dissociative side effect in other studies. So ketamine and suicidality, this is something that was sort of discovered by matter of fact. In the trials looking at depression, they also found that a lot of the patients were reporting who were suicidal being less suicidal or no longer suicidal at all. And so a lot of the data that we have so far looking at this phenomenon is secondary to what was originally being looked at, which is the response to or the effects on depression. There has been one study that was designed specifically to look at this, and so far where they are is that ketamine seems to certainly decrease people's suicidality as rapidly as the decrease in depression. And even though it seems intuitive that the decrease in depression is related to the decrease in suicidality, what would be really interesting and what a big question is there something about ketamine specifically, aside from just improving depression, that decreases people's consideration of suicide? Is there something that stands apart from the improvement in the depression regarding suicidal thoughts in particular? And that's a really interesting question, and so far it seems like the decrease in suicidality cannot be entirely attributed to the change in depression scores. This is really phenomenal because we don't have anything in psychiatry that reduces suicidal ideation and decreases suicidal thoughts, especially not rapidly. There is evidence that lithium decreases suicide and suicidal ideation and suicidal behavior, but that, what we call, separates from the placebo, or is only more significant than other treatments at like 2 years out from beginning treatment. So as far as the safety and things that have to be considered is that there is a significant change in blood pressure and heart rate typically with administration of ketamine. I think it's real important to pause and discuss what statistically significant means versus clinically significant. So if we were all to go outside, run around the block, come back here and give a presentation in front of a bunch of people, all of our heart rates and blood pressures would be statistically significantly raised compared to when we were napping in the afternoon, for example. However, that isn't necessarily clinically relevant, and this is something that gets confused a lot of times in literature, and you might read a lot about this, so I think it's good to educate people that predominantly no significant, clinically significant hemodynamic effects have been observed in any of the carefully designed studies and protocols. Also, they're transient. Most of these effects pass within 4 hours, and rarely has any blood pressure or heart rate concerns caused anybody to stop treatment. Oh, and there's no evidence that this gets worse with the repeat dosing. Lower urinary tract symptoms. This might be, in my opinion, this is one of the more important things moving forward that so far hasn't been discussed much. It's a phenomenon that's been observed in predominantly the abuse population. The abuse population has been defined in the literature as people using nearly every day and as much as a gram a day of ketamine. Usually these people are also polysubstance users, and so it's unclear exactly the role of ketamine alone in this phenomenon, but they know that it does seem to be linked specifically to people who use ketamine in high quantities. What it is there is a something is toxic to the lining in the bladder, and you can get basically sloughing off and cell death in the bladder. People who have used ketamine have been known to present with blood in their urine. Scar tissue can develop in the bladder. If that scar tissue obstructs the outflow of urine from the bladder, the fluid can back up and create high pressure back into the kidneys and can ultimately lead to kidney failure. That's sort of like the long-term sequelae of untreated LUTs. Again, this hasn't been found yet in any of the studies, but it's unclear where in the continuum these kinds of things start to develop. Somewhere in between 3 times a week for several weeks and a gram a day for years, something happens to people's bladders. And so that's something to be aware of. Ketamine has been around for a very long time, but ketamine has not been used medically in repeat doses for a very long time, so something to keep an eye on. The psychotomimetic and dissociative effects. Psychotomimetic means mimicking psychosis or psychosis-like. This is measured often in the studies involving ketamine and is a regular talking point in the literature and even in academic discussions about ketamine. Again, these effects are transient, almost always resolve by 4 hours. Rarely do any of the subjects complain about them being distressing or something to avoid or something concerning to them. Rarely causes anybody to stop treatment. And there's evidence that with the repeat dosing studies, these psychotomimetic and dissociative effects improve with repeat dosing. And different routes of administration seem to show different intensities of these effects. For example, oral ketamine doesn't seem to be associated with much psychotomimetic effects at all. Other adverse effects that people report, again, transient. All of them are dizziness, lightheadedness, nausea, vomiting, drowsiness, weakness, and headache are most common. And I think this is maybe one of my favorite things to talk about is this term psychotomimetic. Psychotomimetic is an old word that's been used for a long time, especially if you read the old literature about psychedelics before they were called psychedelics. Psychedelics was a word that was developed because when they originally discovered LSD, they felt like this was a molecule that was going to give them a model for inducing a transient psychosis and give us an opportunity to study treatments and the phenomenon of schizophrenia in people, for example, in ways where we could induce it temporarily and they would recover from it and would be essentially fine afterward. And that turned out not to be the case. The more they looked at it, the more they discovered that the psychedelic experience is not the same thing as a psychotic experience. Psychotic experience typically can have extreme paranoia, disorganized thinking, auditory hallucinations. Pretty rare, actually, with psychedelics. Also, psychedelics, the classics, work primarily on the serotonin system, whereas psychosis seems to be somehow, at least a part of the working model for psychosis involves a dopamine, a completely different neurotransmitter system. So after that was discovered, they were looking for a new word, and I can't remember who it is that coined.
Osmond.
Humphrey Osmond. Yeah?
Yeah.
Thank you. Humphrey Osmond coined the term psychedelics, meaning mind manifesting, if I believe.
He was doing LSD research on alcoholics, and the idea was you can induce the delirium tremens associated with alcoholics wanting to quit. Because if it's psychotomimetic, well, if it gave them this delirious psychosis, why not induce it with the psychotomimetics? And they were wanting to quit, but it wasn't because it induced the delirium tremens. So Osmond had to come up with a different explanation.
Thank you. Yeah, that makes total sense. So they were trying to basically induce the terrifying symptoms of delirium tremens that usually frightens or has the potential to frighten alcoholics into rehabilitation. All right. So interestingly, they use some scales to measure psychosis, and some of the questions on these scales could overlap with a psychedelic experience as well as a psychotic experience. And the actual scores on these in the studies where they administered, the BPR says the brief psychotic rating scale, I believe, are actually not terribly impressive, but they are different from people who receive saline, for example. Another interesting fact about this effort to decrease the psychotomimetic and dissociative effects is that there's now been, with the discovery of ketamine and a proposed model that this receptor called the NMDA receptor is somehow involved in the glutamate system, another molecule in the brain. Since that has gotten a lot of buzz and a lot of interest, they've looked at a lot of other NMDA receptor modulators, and so far, all of the NMDA receptor modulators that do not create any kind of dissociative or psychotomimetic effects have not shown any benefit for depression. NMDA receptor modulators that do cause dissociative or psychotomimetic effects include nitrous oxide, which there was a study done last year that showed nitrous oxide is having rapid onset of benefit for depression. And one of the big teams that was getting a lot of NIMH funding, which is the big mental health government funding agency, one of the teams that was doing the ketamine research got a big drug company grant to look at dextromethorphan, which is the agent in cough syrup that people sometimes abuse for the dissociative and psychotomimetic effects, I guess. That's being looked at as a possible antidepressant agent among many other molecules in this excitement to find something like ketamine that can be patented. The dextromethorphan study just finished like a week ago, 2 weeks ago, and we're excitedly awaiting the results of that. Also, I believe ibogaine is an NMDA receptor antagonist, works on these same molecular system as well as others, but is kind of famous for its psychotomimetic and dissociative effects as well. Let's see. There's actually, in efforts to try to find out what it is, if there is there any indicators of who will respond to ketamine and who will not. One that I didn't mention here is a family history of alcoholism, which is interesting because it is an NMDA receptor antagonist at high doses and runs in a lot of families with depression. People with a family history of alcoholism are more likely, according to one study, to respond to ketamine treatment. And another review found an association between the degree of dissociative effects specifically and the antidepressant outcomes, though there's been some other studies that tried to look at that and didn't find that correlation. Again, so far they've been looked at as sort of pesky side effects to be avoided, to be minimized. Other drugs are being actively investigated that don't have these side effects. And again, not too much success with those ones yet. In my opinion, it's worth considering that these side effects are more consistent with a psychedelic side effect, as the abuse or recreational use population will probably attest to. So far, there has been a lot of promise with classic hallucinogens like psilocybin and MDMA, with demonstrating not only that they're beneficial for depression, PTSD, end-of-life anxiety, addictions, but also that the degree of mystical experience is correlated with in specifically Roland Griffith's study with nicotine cessation, tobacco cessation. The predictor of abstinence was the degree of mystical experience achieved by the participant, not the dose or any other factor. And in those studies, they take into account set and setting. That's a big part of the protocols if you read those papers, which is not something that's been taken into account yet in ketamine, and I propose at least attempting to take that into account in future studies to see if perhaps that accounts for this differential amount of evidence for a correlation between the dissociative effects and the antidepressant effects. So, in summary, ketamine has been shown to be efficacious for people who have failed trials of the more conventional antidepressants, both unipolar and bipolar depression. These benefits have been shown to be extendable with repeat dosing of ketamine, so far fairly safely. Ketamine can rapidly reduce suicidality as well as depression. IV route of administration has been the predominant strategy so far, but there is no evidence to suggest that this is the only route that will work. And there's also no evidence to suggest superiority of IV administration over any other routes of administration. It's generally well tolerated, and all adverse effects that have been reported so far anyhow seem to be transient and not of particular distress to the participants. There's still this question about LUTs that everybody must keep in mind in any future pursuit of ketamine for this purpose, especially with repeat dosing. The fact that a population of heavy and frequent users of ketamine, the fact that they exist is cause for concern about potential abuse and diversion. People acquiring it for non-medical purposes and distributing it for non-medical purposes. And the psychotomimetic and dissociative effects are typically transient, non-distressing, and may even play a role in the antidepressant effects. References to this paper. And that's all I got. I was hoping to have Dr. Early come up before we open to questions. So if you have any, please write them down, and we can kind of both be available for questions. He's as familiar with this research as I am, for sure.
My talk is going to be more about some of the challenges involved in trying to develop and disseminate treatments like ketamine, because I started out working with anesthetic agents in psychiatry back in 1999 when I got a couple of grants to look at a different anesthetic agent. And when I started this work, I had, I think, a common misconception, which is that in medicine, we always get the best treatments out there, and discovered. Pardon?
Can you turn the screen? That's good, thank you.
Good. And discovered that this was not the case, and so one of the lessons of the ketamine story, I think, is that there are many treatments, not just ketamine, that are very effective and should be available for people, but for reasons that I will discuss, do not become available, and sometimes even go extinct when they're and maybe even are replaced by treatments that are inferior. And this is a very striking finding. That some of the early work that I did with an anesthetic agent called sevoflurane, which I'll talk about very briefly here. One of the criticisms by a reviewer was that if it was such an effective treatment, it should have taken off in the mid-'80s when initial work was done by an Austrian psychiatrist named Dr. Gerhard Langer, showing its benefit. And I actually called up Dr. Langer and asked him about this, and his experience was exactly the same as mine, that he had done work with it for years. It was a very effective treatment. It worked every bit as well as electroconvulsive therapy. It had no memory problems, but eventually he could not find anybody that was willing to learn how to do it or invest the income in making it available. And eventually he and his entire team went into private practice, which is essentially what I did. I think it's probably true that I've left 2 jobs trying to do this research, because it's extremely difficult to try to do this research in any kind of an institutional setting. This is not the sort of thing the department chairman and hospital legal staff and so forth think of kindly when you try to talk about using a psychedelic drug to treat treatment-resistant mood disorders. But anyhow, in the late 90s, I was at the University of Texas in medical branch in Galveston, and I had a large cohort of patients with treatment-resistant depression. And as Cole said, 20 to 35% of patients with depression just don't respond to everything we can do with them in terms of antidepressants. And if you don't know anybody with depression, you maybe don't have an idea of how damaging depression can be to a person's life, that people can become bedridden, and suicide is one outcome, but sometimes lives are just destroyed by depression. And the antidepressants that we have are really not all that good. Recently it's been discovered that the difference between active antidepressant and placebo is not that great. It's inflated by placebo response and a number of other factors. Something called the file drawer effect, that when pharmaceutical companies do these studies, they have a tendency to take the negative studies that don't tend to serve their financial purpose of getting the drug on the market and throw it into a file drawer, so that what ends up being estimated from the literature is much less of an effective solution than you expect. And another thing that happens is that when pharmaceutical companies are studying an antidepressant, they want to get their product that they've invested a lot of money in into the market. And so what they do is they screen out the treatment-resistant mood disorder patients that we're talking about here. So that most of the literature concerning all currently available, and certainly the newly patented antidepressants, does not concern treatment-resistant mood disorders, and very little of it is in the form of long-term studies, which is kind of funny, because this is one of the criticisms that our opinion leaders in psychiatry frequently make of ketamine, is that we need to have more data concerning its efficacy and more long-term data. None of that data is available for the treatments that are heavily recommended for treatment-resistant mood disorders and used every day. That, in fact, we have far more data concerning the efficacy and safety of ketamine for treatment-resistant mood disorders than just about anything else that's being marketed. Anyhow, so I titled this talk The Ketamine Revolution, because I think ketamine is a revolutionary treatment in psychiatry, that it can and hopefully will transform what we can do in psychiatry with some of our most treatment-resistant and challenging patients. And this is a case I saw about 6 years ago of a woman who was admitted to the intensive care unit following an overdose. And she had a history of intravenous drug abuse, a bipolar II depression, and had a leg abscess from injecting drugs into her leg. And she was severely suicidal, to the point that when the nurse turned around after drawing blood from her, she attempted to hang herself in the intensive care unit, and was agitated and put in 4-point restraints. And I came to see her in consultation, and she was bucking against the restraints and talking about if she could get loose, she would go out on the street and kill herself immediately. I mean, this is the sort of severity of depression you see. And we tried the standard treatments, olanzapine, Zyprexa, and haloperidol plus lorazepam, and it did not calm her. And so I talked with an anesthesiologist, and we gave her 100 milligrams of ketamine and 6 milligrams of a benzodiazepine called midazolam. And she went to sleep for about 4 to 5 hours, and when she woke up, she was totally different, no longer suicidal, motivated for recovery from substance abuse, totally different perspective. And over the course of her hospital stay, we had to debride her leg abscess, and opiates did not control the pain for that, but ketamine did. And so this is just an example of the remarkable effects that we can see with ketamine, that it's just transforming, life-changing for patients. So I'm going to talk about the use of ketamine from a clinical perspective, based on my personal use in now 189 patients, plus some additional patients in Texas when I was doing it there, and over 2,300 IM and IV treatments, and over 50 intravenous and oral treatments. But I'm also going to talk about challenges to disseminating ketamine. You know, why is it that this safe, useful treatment is not more widely available? You know, and discuss the potential use of ketamine for conditions other than depression. I'm particularly interested in developing its use for post-traumatic stress disorder and combining it with psychotherapy for some of these patients. So this is the treatment that I initially started out doing research with. We called it burst suppression therapy. It involves the use of one of the halothane the halothane anesthetic agents called sevoflurane. And see, this is an EEG, a patient receiving electroconvulsive therapy, and you can see that there is brain seizure activity, and it gradually kind of changes its amplitude, and then it gets to a point where the brain's endogenous anticonvulsant system kicks in, involving things like adenosine, shuts off the seizure, and produces a flatline EEG for a period of a couple of minutes or so. And what Dr. Langer discovered was that you could get the same flatline EEG by using, he used isoflurane, we use sevoflurane, if you go up above the dose that's used for surgery all the time. So that Ordinarily, when we use sevoflurane for surgery, it's inhaled at a dose of around 2 to 3%. And a simple technique involved just cranking it up about 8%. And within about 5 minutes, the brain goes through, actually goes through a period of what's called burst suppression. These are bursts. And you can see the morphology of the burst is the same here. So, the brain has pacemakers just like the heart has pacemakers. They're scattered throughout the cortex and thalamus. And gradually, if you increase the dose of the halothane anesthetic agent, you clinch all these pacemakers, and the brain goes flat. The EEG goes flat for a period of time. And during this time, there's about a 30 to 40% reduction in metabolism throughout most of the brain. Interestingly enough, there's a little structure called the habenula, which actually shows increased metabolism under burst suppression. And Langer demonstrated in an open label trial and in a blinded comparison to electroconvulsive therapy that basically you don't need to have the seizure with ECT to get the therapeutic benefit. And the advantage to this is that if you don't have a seizure, you get rid of the memory problems that are the main concern that we have with electroconvulsive therapy. And so I was quite enthused about this, and I actually went to Dearborn, Indiana, or Illinois, I think, the home site where sevoflurane was being made, and gave a presentation about it. The sevoflurane was coming off patent, so there was no financial incentive for anybody to develop and use this treatment. And I gave lectures about this for many years, and people were always interested in it. I had exactly one other physician want to learn how to use this technique and attempt to use it. Okay? So it involves quite an investment of time and effort to learn a new technique. And this was one that required a hospital, an anesthesiologist to intubate the patient. The procedure took about a half hour door to door. And the patients, I had the opportunity to use it with many patients that were being treated with electroconvulsive therapy. And virtually everybody, I think, preferred it to electroconvulsive therapy. I'd dearly love to be able to provide this treatment, but there's no way to provide it. No way to transcend the financial and regulatory obstacles to making this available to people. And let's see, this is just one slide. This is our remission with burst suppression therapy in the black bar compared to remission with electroconvulsive therapy in the comparison group. We did 35 patients as an add-on open label trial, and then we did another 35 patients with half of them randomized to sevoflurane and half of them randomized to bifrontal electroconvulsive therapy. And it was every bit as good as electroconvulsive therapy, just like Dr. Langer said. But there was just no way to get it out there. But it kind of, it made me realize that it was possible to rapidly have an antidepressant effect with a drug. And I wondered whether or not there might be a drug that would be rapid acting like ketamine that would do the same thing, and that would obviate the use of could possibly be provided without an anesthesiologist we couldn't pay for, and a hospital emergency room that we couldn't pay for, that maybe would be helpful. Now, hanging around with anesthesiologists, a lot of the interesting developments in science come at the interface between two different areas that usually don't communicate. And so I had the opportunity to spend about 2,000 hours or more hanging around with anesthesiologists, where I would hook up the EEG and read it and titrate the sevoflurane dose to get the brain flat for 2 minutes, and work with the patients, rate them, and so forth. And so I began to kind of look at the world from their perspective and see a great deal of potential for anesthetic drugs in general with psychiatric problems. And let's see here. Well, this is the summary of the sevoflurane therapy that was comparable to ECT in efficacy, was without cognitive side effects. Recently, a psychiatrist in his group at the University of Utah in 2014 replicated again Langer's work with isoflurane, but I strongly suspect that this useful treatment will not get out there, even as much as it should be available, as much as there are many people that would benefit from it, because there's just no way to get past the red tape and the financial articles, or the financial hurdles. I've talked with Dr. Weeks about this, and I don't know, at this point, I don't know what the solution is. Another thing that I stumbled across when I was working with the anesthetic agents was I had a patient that had very severe bipolar depression that was on maintenance electroconvulsive therapy, which is something that we do when everything else fails. And she was getting electroconvulsive therapy treatment every 2 to 4 weeks or so to prevent her from being suicidal and to allow her to function. And she also had very severe post-traumatic stress disorder. And I think everybody here probably knows what post-traumatic stress disorder is. This is where we have an exposure to severe psychological trauma, and this produces recurrent intrusive recall of fear memory associated with things like flashbacks, freezing, nightmares, hypervigilance, avoidance behaviors. And we know a little bit about this from animal studies where fear conditioning is used as a model for post-traumatic stress disorder. And we know that there are two ways of remodeling the fear memory, one being developing the extinction memory that competes with the fear memory and eventually displaces it. And then more recently, there's some interesting work with blocking reconsolidation, that you can actually activate the fear memory, just like deleting a file on your hard drive. You can do various processes that prevent the memory from being relearned or reconsolidated, which involves change in synaptic weights. Complex PTSD is a subtype of PTSD that involves attachment trauma. This is where typically, most common probably, this is where you grow up with an abusive parent or caregiver, and you have repeated trauma from someone that you have to depend on for care. And so you have the emotional conditioning effects of post-traumatic stress disorder along with the attachment trauma. And this is a little bit more difficult to treat. It's often associated with chronic pain or other problems in trust and relationships and so forth. And we'll come back to that in a moment. But anyhow, at any rate, I had a patient who had a traumatic memory of when she was a child, and her mother would come home from work, and if she hadn't cleaned the house perfectly when she was like 8 or 9 years old, her mother would make her stand there and put her arms out. She'd take a pin and stick it into her arms. And so when we were trying to get a catheter in to do electroconvulsive therapy with her, it was a very strong contextual cue that would produce freezing and dissociation and hyperventilation. And we had a great deal of difficulty putting her to sleep without using high doses of anesthetic agents that would interfere with the treatment. And some of the literature on fear conditioning as an animal model of PTSD was beginning to come out then. And I was on a thesis committee for one of our MD PhD studies that was studying this, the role of the AMPA receptor in fear conditioning. So I was kind of familiar with this research, and I stumbled across this old literature of how to treat post-traumatic stress disorder using anesthetic agents. Okay, and we know from work mainly by Joseph Ledoux initially that with fear conditioning we have something like a foot shock, and we pair it with something like a tone, or it can be a flash of light, and repeated pairings of the foot shock produce an emotional memory, a fear memory. And then when you just present the tone alone, you get the fear response that you would get with the foot shock. And so this shows that when you present the tone alone, there are two routes into the amygdala, which is where the fear memory encoding occurs. One goes directly from the auditory thalamus directly to the amygdala. Another one relays through the auditory cortex and gets a little bit slower route into the lateral nucleus of the amygdala. This is probably why when you're walking out in the woods and you see something that for your first flash looks like a snake, you jump, and then your auditory cortex recodes it, and you're able to have a better understanding of what's going on and kind of limit that. It's also probably why some people with post-traumatic stress disorder become so adept at avoiding and numbing that they don't develop an extinction memory. At least this is one of the hypotheses about that. One of the things that happens here when you trigger the fear memory is that the central nucleus of the amygdala sends out activation of various components in the brain that produce aspects of the fear response, so that production of cortisol comes from the paraventricular nucleus, the hypothalamus. Blood pressure changes come from the lateral hypothalamus, the subcortical organ. And the projection to the central gray produces freezing. Okay, so this is why when we trigger the fear memory, people become very anxious, and they very often cannot continue to discuss or to revisit the fear memory, so they can't develop an extinction memory of the fear memory, or the freezing. So I had the thought that maybe we could use a sedative agent to block the freezing response, and so we end up doing that, and discovered this older literature on using what I like to call facilitated psychotherapy to treat post-traumatic stress disorder. we used a drug called propofol, but interestingly enough, I had used Amitol throughout my entire career treating conversion symptoms, and I was not familiar with this literature about using sedatives to treat post-traumatic stress disorder, but it worked like a charm. So we, with an anesthesiologist present, put her on a propofol drip, and then had her describe the traumatic memory that she had, and we could titrate the propofol to the point that her anxiety was relieved and she could discuss it without freezing, hyperventilating, and had her go through it several times. Did prolonged exposure therapy, which is basically an imaginal desensitization therapy that Edna Foa and others has developed. Tape recorded the sessions, and then after an hour session in the OR, we were able to put her to sleep without her having hyperventilation, dissociation, and freezing. And so it basically worked just as good as the old literature said that it would work. And we did this for about 6 months, and then we lost venous access, and she had to have a central line put in. And it took about a half hour to do it, and this reinstated the original fear memory, so she was having anxiety again, but we just did the same thing again. We just treated the fear response. And another thing that she was traumatized by was she'd never been able to have a sensation of water on her face in her entire life. She was 48 years old because her mother would actually hold her head under the water and threaten to drown her. And we, again, treated this with propofol desensitization, had her bring in a bowl of water, splashed on her face, put her face in the water. For the first time in her life at age 48, she became able to shower, and I thought this was quite a striking finding. Here's this this treatment that the old literature, if you look, there's plenty of articles on it. It was used as kind of one of the standard treatments for what was called traumatic war neurosis right up until about the time of the Vietnam War. But then at that time, several things probably accounted for it going extinct. One was that the new psychopharmacology was developing, and people were very enthusiastic about the ability of these new drugs to treat everything, and of course they don't do that. But it's also inconvenient to do these treatments. You have to get on an OR schedule that, again, involves doing things that psychiatrists are not usually inclined to do, and it just, for a variety of reasons, went extinct. And I'll come back to that toward the end of the lecture, because it's a very, very important point. Why is it that some very effective treatments go extinct and are actually replaced by something that's inferior? Okay? So facilitated psychotherapy was used a lot during World War II, also called narcosuggestion, narcoanalysis, or the Amitol interview. And it's basically psychotherapy facilitated by sedative agents or other drugs. And it was used, actually, since the first reports were in World War I. There were two types of facilitated psychotherapy: a sedative facilitated psychotherapy, where you relax the patient with a sedative agent, and then another type involved actually overstimulation using agents like ether. And this is an interesting approach, that this would produce excitation to a point where the person would then suddenly lose muscle tone, have catalepsy, and they would kind of swoon like you. And actually, you see this in tent revivals with religious conversion. One of the authors, William Sargent, thought that there was a common physiological state that was accessed here, and then they would wake up and they would not be bothered by the intrusive thoughts, flashbacks, nightmares, so forth, that were part of PTSD when they woke up. And if you want to look up on YouTube a movie called Captain Newman, MD, you can see this technique used with Bobby Darin. And it was, I think it's kind of remarkable. It was such a standard treatment that it was featured in movies at the time. This is during the Korean War, but it's totally dropped off the map, so much so that psychiatrists and the general public don't remember using this. They don't even think about it. The last study I could find was by a psychiatrist named Lawrence Cole in 1985, and he looked at 19 patients with combat-related post-traumatic stress disorder, and then he used Amitol for partial sedation and played combat sounds. And 14 out of 15, 15 patients had an abreaction, which is to say that they had an emotional recall of trauma, And he followed these patients up for 2 years. And they had a different conceptualization of PTSD then. This is before DSM-3. But at 2 years, 14 out of 15 patients were free of panic and dissociative states 2 years of that follow-up. And compare this with our standard treatment nowadays, serotonin reuptake inhibitors, which have a very high dropout rate due to active avoidance, a time lag to response, and probably at least 50% of non-response. And they just don't, medicines don't work that well. That's a real kind of problem with post-traumatic stress disorder. So it's a very striking finding that here was an effective treatment that could be done in an hour, or maybe a limited number of hour-long sessions that would treat flashbacks, nightmares, hypervigilance, and so forth. It's gone completely extinct, and it's been replaced by an inferior treatment. Okay? Very striking finding. Well, I got into, when ketamine came out, I got to using it fairly early on. I was at Baylor College of Medicine, and then I ran into so many roadblocks there that I moved to Santa Barbara and worked at Cottage Hospital and had a private practice. Of course, I had some kids coming up from college and other reasons too. But I got interested in trying to provide ketamine in my clinic. And I went to study with a Russian psychiatrist named Eli Kolb, who was living in the United States down in Tampa, Florida. And he had collaborated with Dr. Evgeny Krupitsky in studies beginning in the mid-90s looking at ketamine, what they called ketamine psychedelic therapy as a treatment for substance abuse. Okay, and now there are several interesting points about this literature here too, that Krupitsky, this is kind of a follow-up on the LSD research. This was a way to provide a psychedelic experience with a medically available agent. And so Krupitsky did a study where he looked at 100 patients with alcoholism admitted to the Moscow Narcological Institute, and he gave them 1 month of basically alcohol rehab therapy and 2 sessions of what he called KPT, ketamine psychedelic therapy. And he compared these patients to another 100 patients that were part of the alcohol rehab therapy but didn't have KPT. And at 1 year, 65% of the patients that had KPT were still sober, compared to 24% in the group that received the similar psychotherapy without ketamine. Okay, so pretty striking finding and pretty good results for alcoholism. And he had some very interesting results with showing kind of changes in what we call psychospirituality, which is kind of the spiritual component of recovery, the change in worldview that people get when they get sober. And then Dr. Eli Kolb reported comparable results later on. But it's interesting that he was at the University of South Florida, and I'll give you a little bit of background on him. He became quite enthused about this, and he was working at a VA hospital, and he wrote up a protocol to try to study it, and unfortunately his chairman was just leaving, and a new chairman was coming in, and the new chairman said, well, let's not do this now. Let's let me get my feet underneath me, and we'll do it later. And so he went and worked, doing clinical work for another year. Came back, and the chairman said, "Oh, I'm afraid this is just too controversial. We're not going to do it here." Okay. So he went into private practice and developed a substance abuse treatment program, and provided ketamine psychedelic therapy for many years there. And interestingly enough, one thing that he said that we'll come back to later on was that he initially thought that ketamine, because it was an NMDA receptor antagonist, that its effects with alcoholism were purely pharmacological, because alcoholism does tend to produce activation, hyperstimulation of the glutamate receptor. But he found that until he had a very good psychotherapy program complementing the ketamine, that he didn't get the results that Dr. Krupitsky had. So that gets back to what Cole was saying earlier about setting being part of the therapeutic effect with ketamine. Also showed benefit with opiate addiction. Ketamine reverses tolerance to opiates and was helpful in treating opiate addicts, although the effects were not as robust as with alcohol. Now, so in 2009, I went to visit with Dr. Kolb and had him give me an IM treatment of the higher dose, more like 1.5 milligrams per kilo that they typically use, which produces a very striking psychedelic effect. With the first time I had it, I had what Dr. Kolb calls an ego-dissolving state, where you lose track of who you are and where you are and when you are, of having a body. I remember feeling just like a spot on a whirling sea of consciousness, and it was a very striking experience, but he had the most experience in the country of anybody using it. Another interesting thing about this is that as much money as we spend on treating alcoholism and substance abuse, nobody in the United States has attempted to replicate these results with a federally funded study. Okay? And this treatment, as valuable as it is not available widely for addiction or alcoholism in this country. And,
It's ridiculous.
excuse me?
It's ridiculous.
It is ridiculous, yeah, it is, it is. But it just kind of shows you the bias against interventions in psychiatry and modern treatment. But it reflects the mindset too that, you know, unfortunately, psychiatrists have somehow become conditioned to think that the only effective treatments are newly patented, rather expensive pharmaceutical agents that just go on the market. And that's just not the case. But ketamine works on many different levels. And another thing that, this is a vision I had during my ketamine session, was a peninsula covered with lights that were, the nodes were kind of interconnected. And about 10 months later, I realized that it was the peninsula of Florida, where I was, because it was in Tampa. I didn't realize it at the time. And I had done a lot of thinking about how difficult it was to promote and disseminate these treatments, and the nature of suffering and so forth, and going into it. And the thought that I had was that each node of this network represented a human life of someone that was currently living or had lived, and the connections between the lights reflected the necessity that we have of connecting with each other to bear the pain that is a part of every human life. And it's still a lesson that I carry with me. So I think, you know, that as much as we get benefit on a pharmacological level and many other levels, that there is a kind of a spiritual component of recovery that we can get if we take advantage of with psychedelics that has to do with accessing a state of mind that is described in basically all modern religious traditions as an outcome of meditation, or Sufis do dancing or what have you. And this is the sense of connectedness, that we're all one. And I think the ego-dissolving state. I went back to a conference that Dr. Culp had with some of the interpersonal, transpersonal psychologists, and we had quite a discussion on whether or not the state was the same as described in various religious traditions and psychedelic drugs, and there was an interesting discussion about that. But one of the people that attended the conference was someone who had a lifelong history of OCD and depression, and had been able to get into the ego-dissolving state just with very intense meditation. And this lifelong illness he had went away for 9 months, and then when he came back, it was not as severe. So that
I've had that too.
pardon?
I've had that too.
You've had that too with meditation?
Yeah.
Yeah. Did it help? Yeah. So, treatment dissemination. I'm going to come back to this. Why does an effective treatment go extinct to be replaced by less effective treatments? Do effective treatments sometimes fail to get adopted? You know, early on I thought there was a good chance that ketamine would not get out there, and I still think that there's a possibility that it may not become widely available, or that it will become available in such a contorted way that people will not be able to use it effectively. And I think that's something we have to watch out for. And why would we in medicine fail to use all effective treatments, particularly if there are not better options? And because this is not a problem with just psychiatry, that in all areas of medicine there are treatments that could be used but are not used. One example I heard about was when a child is born premature, they have respiratory distress syndrome. Their lungs are not fully developed. And the best treatment for this was, I think, nitric oxide. And the only source of nitric oxide were welding supply stores. Okay, so that, but you know, pediatricians and ICU doctors could just imagine, you know, having to talk to some, you know, plaintiff's attorney about why in the hell did you take this tank of welding gas and have the infant inhale it. And so it finally took somebody buying up all the suppliers of nitrous oxide, nitric oxide, and labeling them as medical gases and selling them back at a considerably elevated price. Another example of this, I think, is fecal transplants for C. difficile. You know, that there are some treatments that just, for a variety of reasons, just don't get out there. Okay. So, facilitated psychotherapy. And here I'm going to talk a little bit about ketamine as a plasticogen, because I've come to think of ketamine as being kind of a universal solvent for psychotherapy, something that can facilitate the type of learning and the changes in the brain that we hope to occur with effective psychotherapy. And one of the things that's interesting about psychotherapy at this stage is that we are beginning to understand it in terms of the brain systems that we interact with and hope to change with learning. And so we're beginning to understand not only what medicines might be helpful, but what psychological techniques might be helpful. For example, the involvement of the amygdala in emotional conditioning as a component of post-traumatic stress disorder is a very important part of this. Okay, here's case number 2. This is someone I saw in 2007. This is a 38-year-old nurse who had unipolar depression, severe post-traumatic stress disorder from severe traumatic abuse and a large dysfunctional family growing up, and severe back pain from an automobile accident. He was wearing a back brace, and he was on about 90 milligrams a day of methadone, and we did IV ketamine to treat the pain, and it treated the depression, and surprisingly got rid of the daily flashbacks and nightmares that he was having from his post-traumatic stress disorder, and allowed him to taper off all of the opiates and get out of the back brace. Okay? And when we provided the ketamine at a 2 to 3 week interval, it controlled his PTSD and depressive symptoms and pain. Okay, and so it was just a very good treatment for that. And this is typical of many of the patients that we see that have this combination of depression, post-traumatic stress disorder, chronic pain, that they do better with this. So far, the data concerning ketamine for post-traumatic stress disorder is rather limited. Federer 2014 demonstrated benefit for PTSD in a study of 41 patients assigned to ketamine or midazolam being kind of an active comparator that produce an altered state. Ketamine produces a period of decreased anxiety to trauma triggers. And so I think it's most effective when you combine this with an exposure-based psychotherapy like EMDR or prolonged exposure therapy, that something that has proven benefit for PTSD, and it will enhance the ability to take advantage of the exposure-based psychotherapy. For example, one of my patients had trauma associated with exposure anytime she was in the presence of a rodent, because her initial trauma involved her assailants capturing rats and using them to bite her. And following ketamine, the day following ketamine, she was able to go into a pet store and pick up and handle rats, which she'd never been able to do in her life before, and self-expose and get past this particular trauma cue or trauma trigger. I've really come to think of 2 poles of symptoms with post-traumatic stress disorder, one being a pole associated with the amygdala, the emotional conditioning component, which we know most about fear, but other emotions are probably part of this here too: guilt, shame, anger, and so forth. We know less about that and about how to alter that with effective psychotherapy. But then the attachment system, okay, is another component of it, because and this is an area I didn't really know anything much about until about 4 or 5 years ago, I began to read about it and educate myself about it. And I think it's a very important part of the ketamine effect. But probably many of you know about this story that it begins with a gentleman named John Bowlby, who was a psychoanalyst in London in the 60s, who was seeing a lot of people who had been separated from loved ones during World War II, and he was treating them for depression and anxiety, and he became interested in the role of the separation during childhood upon the adult symptoms of anxiety and depression. And his college roommate was this guy, Harry Harlow, that probably everybody has seen a picture of these little rhesus monkeys in a cage with a wire mother and a cloth mother. Harlow had studied bonding behavior in rhesus monkeys, and so Bowlby's work was informed by this animal literature on what sometimes is called imprinting behavior. He teamed up with a woman named Mary Ainsworth, who was a single mother that had an interest in this topic and had studied it, I think, in New Guinea, and I believe she was his graduate student. And they did something called the infant strange situation, where they would take a mother in a room with a 2 or 3 year old child, and a stranger would come in the room, and the mother would leave the room for 5 minutes and come back, and they just simply recorded what did the child do during the period of separation and reunion from the mother. And surprisingly, they could identify 3 patterns of behavior that were reproducible, and that if they looked 6 weeks later, they saw the same pattern of behavior. 2/3 of the time, the children had what was called secure attachment, which is pretty much what it sounds like, that when the mother left the room, the child would fuss, but kind of settled down. The stranger was friendly. There were toys in the room. Would reach out for the mother when she came back in and get picked up and rapidly soothed. Could be the father, his primary caregiver. There was this kind of nonverbal communication that was obviously healthy. The other third of the time, the children had what was called insecure attachment, and it took one of two forms. One form was called hyperactivating attachment. And in this form, the child became very upset and distraught and fussed and cried during the entire period of separation from the mother, became even more emotionally aroused when she came back in the room, maybe had some anger and took quite a while to settle down. And the other type of insecure attachment was the opposite. It was called deactivating attachment. And in this situation, the child seemed not to notice when the mother left the room, would actually turn around, crawl away, and resist being picked up when she came back. But if you measured cortisol and stress hormone levels that were elevated, the child was obviously stressed. And so Bowlby and Ainsworth reasoned that we have evolved an attachment system in our brain, like we have a system for vision, a system for hearing, and so forth. And the function of this with us, as it is with the rhesus monkeys, is to forge and maintain a bond with a caregiver when we're young. Of course, the reason we have this is we're going to starve to death if we can't solve this first most basic task. And that in the best of circumstances, we can have secure attachment. Sometimes through a difference in genes, environment, we learn that we have to overactivate the attachment system, and we get more of the emotional pain and the behaviors like crying and so forth that help to securely get help when perhaps from a caregiver that's slowly or intermittently responsive. And other times, some babies are just uncomfortable being held, or maybe it's less stressful to just shut off the attachment system than to cry and cry and cry and not get help. And you end up with the deactivating form of attachment. Okay? And surprisingly, when they followed these children up 20 years later in the 60s, they were in their early 20s, they could find a good correlation between the patterns of attachment behavior they had as children and what they showed as adults. That people that had the hyperactivating attachment pattern as children tended to have a lot of abandonment fears, a lot of anxious focus upon relationships, a lot of problems with anxiety in relationships, and those that had the deactivating pattern were people that were uncomfortable with emotional closeness and tended to push people away. And of course, as luck would have it, sometimes these two patterns of behavior get together in a couple, and this is what the marital therapists talk about. So the developmental psychology component sort of converged upon the study of attachment behavior in intimate relationships, and it seemed that the templates that we form as children are adapted later on for adult relationships. Now, broader than that, I think, are the attachment templates that we have with people in general. You know, some people are curmudgeons. They don't trust anybody. Nobody's any good. You know, they tend to keep themselves separate. You know, and of course the attachment schema has an outward-looking component. You know, what do you expect of other people? And an inward-looking component. What do you expect of yourself? And they're not written in stone. They can be changed, and probably changing the attachment schema is a large part of the so-called non-specific effect of psychotherapy. As we become more secure in a therapy setting, we become more able to be secure with people outward elsewhere. But anyway, I got interested in this because I had about 5 patients that had 5 or 6 patients. I now have a few more that would always have a very robust, strikingly robust effect with ketamine.
Thank you.
Came in and had a session and did not have any effect at all. And this occurred in situations where there was some issue involving attachment trauma that came up. That one patient had been brought to a treatment by a female caregiver that was their only female friend, basically, and this female friend had been accepted to a nursing program out of state, and that was the last time that she was going to go in for treatment. Another patient had learned from his wife that she was intending to file for divorce. Another patient, I engaged in a discussion with the father that traumatized her as she was coming out of ketamine, and she did not have an effect, and so forth. So this is kind of what got me interested in attachment and ketamine. Another thing is that I've got a website or an email group of people that are doing ketamine throughout the country, and it's corresponding with David Feifel in San Diego, who did 3 patients, not a single one of them responded. And there's a guy named Luis Jufra in St. Louis, WashU, that did 10 patients, not a single one responded. And trying to figure out, what's the difference here? How is that? How are things different? The only thing I could come up with was the mental state, the setting, that the protocols that we tend to write about how to do things in the hospital involve lots of chrome and a bunch of strangers standing around you looking at you dressed up like a Christmas turkey, and not the best setting to take a psychedelic drug in. This is something that the earlier psychedelic investigators found, that somehow doing LSD on a nice sunny day with friends differs from doing it in a small room surrounded by hospital security.
Do you know if there were actually any adverse reactions to those 13 or 10?
I don't know that they discussed that. I think that probably, I rarely see what's called the emergence reaction with ketamine. That they say that 12 to 14% of people that are anesthetized with ketamine would get severe anxiety and terror coming out of it. I don't very often see that. But I think if you're in a busy emergency room and it's loud and noisy and people are running around not really connecting with you mind to mind, not mentalizing with you, then...
But it is a natural blowback effect to anything that suppresses the central nervous system, or it has that effect on the body. It is a natural response that's triggered in some individuals that are highly traumatized.
That's true.
To have an anxiety response to any depression of the nervous system, because there's such a fight or flight response going on continually with that person with high anxiety.
Surprisingly, though, I've treated some very, very, very severe patients with PTSD, and I've only rarely had it actually produce flashbacks and nightmares during a session. That if you're careful and you make the patient feel safe and you incrementally dose them, it usually does not happen. Actually, it will relieve the PTSD.
Just to follow on, if there weren't adverse reactions, 10 out of 10 is really significant.
Yeah, I would think so, yeah.
So, you need an
Yeah.
it seems like that would be helpful to get an explanation for
Yeah. Well, and
It's
throughout,
not sad.
I've-
Just be sad and sad.
the pain patients I treat, talk about, they go to some clinical settings and they really feel like they're being listened to and they feel safe and secure. And it's very different going to somebody else that is hurried, that's so focused upon the procedure that they don't mentalize with you, they don't connect with you mind to mind. That it's much more of a traumatizing experience like that. And so kind of makes me interested in this whole things. Okay. So basically, treating PTSD involves not only getting rid of the nightmares and flashbacks and the hypervigilance, which generally responds pretty quickly to ketamine, and then if you combine it with psychotherapy, it gets better, but also trying to work with and mold the attachment schemas over time. And that's something that we know a lot less about. There's some very interesting brain imaging research, like Pascal Verteca, showing structures that are involved in the insecure forms of attachment that get activated. And so that I think probably the next 10 years we'll see this come into its own as an area of inquiry. See, this is a study that was done at Yale showing that under chronic stress, the spines on spiny neurons tend to retract. This is in the control group up there, the little knobs or spines on spiny neurons. It's thought that maybe this helps to prevent damage to the nerve cell when you get the glutamate overdrive that occurs with chronic stress. And ketamine, through its actions upon a protein called mTOR, cause these spines to come out. So basically the brain rewires itself so that ketamine, this is, I think some reason why we might think that ketamine enhances the ability of the brain to change. So we've evolved this technique, which I initially evolved years ago when I was treating people with sevoflurane and electroconvulsive therapy. The main focus of a session being creating a sense of safety, what Bowlby called a secure base. And talking about this as a journey of learning and understanding is helpful, because often people do encounter important things involving their own life journey, really, under ketamine. And we start with a 0.5 milligram per kilo, which I give in 2 or 3 separate IM injections. The IM injection produces a peak effect. Usually, you can set your clock by about 20 minutes. You get the peak effect in by an hour. Patients are much better. Usually, 90 minutes after injection, they're ready to go home. And let's see. So this is what Bowlby talked about, that that our caregiver serves as kind of a secure base, and that when we're young, we explore the world, and we get separate from our caregiver, and it produces anxiety, and we seek proximity, and we go back and again kind of recharge our batteries with a secure base. So that ketamine, we try to do a secure base experience, and actually do see attachment schemas coming out during treatment. Patients, I remember treating a lady that had a hyperactivating attachment schema, and began under ketamine to say, I'm taking up too much of your time, I should leave, I feel embarrassed, I feel ashamed, just like she had experienced growing up when her emotional needs were not being met around a large family sheet. And this is this is another way of looking at attachment style. One involves the internal part of the attachment style is looking at your model of self. So if you're secure, you have a generally positive view of yourself that you can cope with stress. If you're insecure, you tend to have a negative view of yourself. Preoccupied is hyperactivating, is the other term for that. And then a model of other, again, positive would be a secure perspective on others. A negative would be dismissing as a deactivating style. This would be a tendency to think that others are not helpful to you, that there's no help elsewhere, and that you can cope with anything that comes up. And then the fearful is the fourth category that was added in later on by Mary Main and others. It was called disorganized. And these are people that have an approach avoidance conflict, that have an extreme need for intimacy and closeness, but at the same time an extreme fear and anxiety of intimacy and closeness. And this generally occurs in a setting where you're forced to rely upon a caregiver that is physically abusive to you. So combining psychotherapy and ketamine, that we strongly recommend doing individual psychotherapy, either provided in the office or in collaboration with the patient's therapist. Sometimes the therapist comes in. Because I'm so busy doing ketamine, I usually try to do this as a teaming up with the therapist that does psychotherapy day in and day out, and that knows the patient pretty well. And then we provided group therapy, focusing upon schemas and automatic reactions, mindfulness skills, and then talking about attachment and something called compassion-focused cognitive behavior therapy that a guy named Paul Gilbert developed, kind of working on trying to explicitly understand and remodel the attachment schemas that people present with, and then understanding and revising the life narrative and meaning. Okay, getting into pain. Pain and PTSD and depression and addiction go together. Okay, this is a patient I saw in Cottage, 89-year-old woman who had depression and had diverticulosis, where she had outpouching of her colon, producing abdominal pain, was on opiates for this, which had the adverse effect of slowing down bowel motility and making the abdominal pain worse, and she just wanted to die. Didn't want to do anything at that point. And we couldn't taper her off the opiates because of abdominal pain, and actually tapering off of opiates tends to produce increased bowel motility, which make things worse. And the ileus reduced bowel motility, worsened the diverticulitis. We did 4 ketamine sessions, and this allowed us to rapidly taper the opiates. She was on fentanyl, get her down to a level without withdrawal symptoms, but we could switch her over to Suboxone, which is a partial opiate agonist, and improved her depression and got her well enough to control her pain and get her out of the hospital. So there are many psychological aspects of chronic pain. It's frequently associated with depression and PTSD and anxiety, and recently there's been growing literature on attachment trauma and insecure attachment and pain, and particularly chronic pain chronification, is what they call it. And we have actually 2 pain systems in our brain. We have a lateral pain system in the somatosensory cortex that codes the intensity of the painful stimuli, and then we have a medial pain system in the dorsal anterior cingulate that is associated with the emotional catastrophic component of pain and suffering of pain. And I've got a slide about that later. Other psychiatric disorders such as OCD and ADD interact with the pain and give problems with addiction or amplification of pain. This is a slide from, it's not a very good slide, but it's from a brain imaging study where you put your hand in a hot container of water, and the hotter the water, the more you get activation in the lateral somatosensory cortex in the upper part. Okay, and then the medial pain system is more involved with the psychological reaction to pain. Ketamine is most literature in something called complex regional pain syndrome, or RSD, that's a very severely disabling condition where the sympathetic innervation in a part of the body is damaged, and there's something called allodynia. The non-pain systems begin to transmit pain signals, and this is a process that involves the NMDA receptor, similar to long-term potentiation as a learning phenomenon. Ketamine reverses this. Also, it's helpful with phantom limb pain. Phantom limb pain is a good example of a pain schema, that when we lose a limb, very often we get this severe type of pain, and it may involve having a sense that the absent limb is contorted in space or twisted behind our back or something like that. It's very difficult to treat, and ketamine is helpful there, but Dr. Ramachandran in UCSD has actually found a way to treat this using a mirror box, which is interesting, that you put the absent limb in a box that has a mirror on it, and then you do the physical therapy movements with the intact limb, and you get this visual feedback that you're actually moving the limb that's no longer there. And somehow or another, this undoes the pain very often, and treats this very severe type of pain. Visceral pain is also useful for fibromyalgia. I've seen some extremely severe cases of chronic daily headache that responded very well to ketamine. IM and intranasal ketamine, like the triptans will abort headache, and I've seen people have had 20 years or more of a severe remitting chronic daily headache that's done well with ketamine. In complex regional pain center, one of the people that I visited with when I visited with Dr. Culp was a guy named Anthony Kirkpatrick, who was the head of the RSD Foundation in Tampa, and he had set up a protocol to look at something called ketamine coma therapy that involves putting people with RSD to sleep for a period of a few days. The idea is that you totally damp down the pain signals. And we're talking about a condition that is severely disabling, extremely painful, one of the worst conditions you can have. And there's some evidence of Germany that this is helpful. He wrote a protocol to do it, was not allowed to do it in this country, and it's available in the University of Tübingen in Germany, and then he's got a group in Monterey that does it, but at a considerable cost. So although the use of ketamine for pain is even much more well documented for depression, it's still not widely covered by insurance. And so I see a lot of patients that can't afford the rate that anesthesiologists would charge, and I can provide it to them because I bill for an hour of psychotherapy, and they can afford it. Okay, so now we're going to get into dissemination, okay? And we're going to talk about two types of systems, okay? And the system that we are most familiar with thinking about scientifically is a mechanical system, okay? Like a clock. It's a linear dynamical system, and basically science runs on mechanical models because it's predictive. You know, if we encounter the more messy, what's called a complex adaptive system, represented here by a cat, we very often will try to produce a linear model to make it a predictable model that we can control and we're more comfortable with. And this is, I think, a reason of why we are missing these treatments, is because we expect medicine to operate like a mechanical system, like the algorithms that we see in textbooks, and we expect everything to work with clock-like precision and the best treatments to come to the front. And it's not a mechanical system, it's a complex adaptive system. So, from a mechanical view, treatments are like scientific facts that are replaced by better treatments as they become available. Valuable treatments will always be adopted. This is the misconception that people have. But the actual nature of treatment evolution is survival of the fittest, but not best treatments. That healthcare is like an evolving complex adaptive system. That better treatments are sometimes replaced by inferior treatments or not selected at all. Just like in an ecosystem, and sometimes we'd like to have the condor, but the mice and other things drive it into extinction, you know. And And pharmaceutical companies and insurance companies largely control selection because the financial incentives for providing a treatment are considerable. And also the legal profession limits what can be done, and this is probably why it's virtually impossible to do ketamine research and make it available. The VA does not have ketamine as useful as it would be for pain, PTSD, depression, all the problems that they see. So treatments are like memes. If everybody familiar with the term memes, probably we know this from a computer, but memes are, this is a term that Richard Dawkins introduced to refer to pieces of information that act like genes and that are good at getting replicated and spread. So they take part in the Darwinian algorithm of variation, selection, and replication with preservation of form. So in the upper left-hand corner is someone that's been cannibalized by a religious meme that has co-opted their resources and put them to the use of spreading the religious meme. This sign on the right used to be on the back of every car, and you still see it occasionally. It's like the memes that are on your computer virus. And unfortunately, some memes don't replicate very well. In the bottom part of the screen here, we have a multidisciplinary pain team. This is what we know is the best way to treat pain, where we have anesthesiologists, neurologists, neurosurgeons, psychologists, and where we tackle all the components of pain. But trying to get all these people together in a room talking to each other and working to each other is difficult in its own right, and then there's no reimbursement for teaming up like this. So these things tend to not occur as valuable as they would be. So treatments are replicators, means, and they're similar to biological replicators of organisms that are selected within an interactive network, an ecosystem, and they compete for selection within an interactive network. The healthcare marketplace and selection is only indirectly related to utility. When I was at Baylor, I called around trying to find how to fund the ketamine therapy, and I called the Orphan Drug Administration, and I finally talked to somebody at the Center for Medicare and Medicaid Services, and they told me that there is no organization in the government that is charged with promoting treatments simply because they would be helpful for people. That everything that comes into use in medicine has a profit motive that is necessary really to transcend the red tape and the financial obstacles to making it become available. Changes in funding are labor intensive. The pharmaceutical companies have people that will call up and hound the agencies to make the drugs available, but nobody's calling for ketamine. That's why it's not going to be available. That's why grassroots effort to promote ketamine is so important. I think if it's going to get out there and become widely available, it's going to come from people that are getting benefit from it. The CPT code for narcosuggestion doesn't really reimburse for the cost of providing it. And so there are several factors that affect replicator vigor. The cost of the treatment, the quality control, how easy is it to control quality. This is an issue with psychotherapy. We all know psychotherapy is helpful, but we can't control the quality of it. So that unlike Prozac, that you can be reasonably sure you've got some Prozac in the capsule when you pay for it, when you pay for psychotherapy, you could be paying for good psychotherapy or something that actually makes things worse, primal screen therapy or something like that. This all comes out of there's a literature on diffusion of innovation that began largely in the agricultural colleges where people were having to disseminate new forms of seed corn and so forth. And this a guy named Rogers has a standard textbook on this that is interesting. But needless to say, when you try to introduce boiling water to a Peruvian village to prevent river blindness, you're not going to get them to adopt it if they have a belief that the heat is a demon that gets into the water and can jump into their body. Okay, that even as good as they would benefit from having sterile water, they're not going to adopt it if it's incompatible with their worldview. So we suffer with the unintelligent design of healthcare, just like the unintelligent design of our bodies, where we have many flaws. That the trachea crosses the esophagus and makes us susceptible to aspiration pneumonia, because the healthcare, like our bodies, is a complex adaptive system and has evolved and is suboptimal, and changes are made by satisfying rather than optimizing demands. Okay, so several issues in the dissemination of ketamine. Who will provide it? We're at a kind of a crucial time where If it has to be provided by anesthesiologists because of excessive concerns by hospital administrators and legal staff and so forth, it probably will inflate the treatment to the point that it will become less available. On the other hand, I think that I'd like to see both psychiatrists and anesthesiologists be able to provide it. Anesthesiologists at a higher dose and combined with other types of agents. How will it be reimbursed? And how will it be adopted by risk-averse hospital and insurance companies who have really very little incentive to cover it? When I was learning about ketamine, and I'm just about done here, I talked with everybody I could find who had any experience with it, and I talked with someone who had done a pain fellowship at the MD Anderson Cancer Institute in Houston. And she said that when she first started doing her pain fellowship, she's a neurologist, that they would quite routinely hang a ketamine drip for people that were getting procedures or that had cancer pain. They had done it as long as anybody remembered. They'd never had any complications with it that anybody could remember. And then one of the nurses complained about the supposed medical legal risk associated with having the nursing staff hanging quote-unquote anesthetic agent on the floor, and they stopped doing it. Okay? And that's what institutions do. It's easier to not provide a useful treatment than to accept the minimal risk that might be involved in doing it. How will ketamine providers be trained? How will diversion or abuse be prevented? Ketamine has an abuse potential roughly comparable to benzodiazepines. And so but it's still a considerable risk, but it's not as bad as methamphetamine or heroin or drugs like that. Also, the night, pardon?
Benzo addiction's pretty bad though.
It is, but if ketamine is provided intermittently, not every day, it's probably less. And actually, for some reason, the oral ketamine so far does not seem to have, at least as far as I've seen, abuse potential in terms of what people have been talking about, what I've seen personally. Nitrous oxide, by the way, is something that can cause B12 deficiency. It binds to B12, and I had a patient actually become unable to walk with it. So if it does become available as a treatment for depression, it would be a risk for that. So, here are some things that we could provide in a psychoanesthesiology clinic where we'd have psychiatrists and anesthesiologists working together. But truly, much better approach to chronic pain. We prescribe a lot of the Suboxone, the partial opiate agonist, that's very helpful for many patients with chronic pain. Anesthesiologists do nerve blocks that are vital very often. Psychotherapy, there are forms of psychotherapy to deal with chronic pain issues. I mentioned the sevoflurane therapy that I worked with early on. That would be something that would be very useful to have available. Facilitated psychotherapy for anxiety disorders. I think not only PTSD, but I thought that this would be useful for obsessive compulsive disorder. Many patients with OCD have such severe anxiety that they can't begin to think about doing an exposure. But you can lower the anxiety with something like propofol and begin them on exposure and get them to get some success with it. My experience with propofol makes it clear that exposure therapy does not have to be painful. That you can have like painless dentistry. You can have a pain-free psychotherapy too. There's a gentleman named Eugene Lipoff that has published some literature on blocking the stellate ganglion in the neck, which has some of the sympathetic innervation in the body going through for post-traumatic stress disorder that looks very promising. Benzodiazepine detox can be done with a partial benzodiazepine agonist called clonazepam. And there's a pretty good literature, including several articles saying, why aren't we doing this? And again, this would be something that would be very useful because the standard advice for benzodiazepine dependence is that you put patients on a long-acting benzodiazepine and gradually reduce the dose. And actual studies of this show that it works about 25% of the time. Okay? So it fails most of the time. There's a recent study of nitroprusside therapy for hospitalized patients with schizophrenia. It's a nitric oxide donor, showing a reduction in psychosis at a month, and then, as well as acutely. We talked with the director of psychiatry, Cottage, and we would dearly love to be able to provide it. We don't know how to provide this. And nobody, as far as I know, has followed up on this, as they should be doing in the United States to study this. Eventually, I think we'll be able to treat addictions based upon techniques to block the reconsolidation of the addiction areas. There's some promising literature in animals that suggests that this could be a helpful approach. So that's all my slides. they usually use more like 1.5 to 2 milligrams per kilo. And I think that they usually would have an anesthesiologist present during that, although sometimes I've worked up to that dose in refractory pain patients because they tolerated it and it seemed to work for their pain. Dr. Krupitsky and Culp have several chapters where they discuss using this. I think I don't feel like I know enough about it to do it confidently with alcoholism, although I do treat patients with alcoholism and substance abuse with ketamine, and it's very often helpful for depression and PTSD and mood disorders and other things that are a backdrop. So I look at that really kind of more as going after the attachment trauma and PTSD. Interestingly enough, there's this literature in substance abuse that talks about attachment. I've got a book called Addiction is an Attachment Disorder, where the idea is that the drug or the alcohol is a surrogate attachment figure. That has the advantage we can buy it, take it home, put it on the shelf. It just doesn't work as well as real human relationships.
My contact information, by the way, is my name, Cole Marta, md@gmail.com. COLEMARTA, MD@gmail.com. And regarding that, Eli Culp has an institute, and I believe his website's like culpinstitute.com or something like that. If you Google Eli Culp, you can find him. He's still in practice in South Florida, I believe.
And unfortunately, they made ketamine illegal in Russia, so Dr. Krupitsky had to stop that research and was doing something else.
I have a question for him. About one of your first slides, you mentioned mTOR.
Mhm.
No one lectured on that, so I know that it's a mitochondrial cytokine.
Right. Yeah, it's been getting a lot of attention in as far as where it came into my paper was how ketamine is sort of opening doors to alternative entire strategies for combating depression that weren't being considered before, and mTOR being one of these identified molecules, but it wasn't something that was part of our review because it just got so nebulous to look into all of the
I'm just kind of surprised
potential
because it does
mechanisms.
create inflammation, which then turns around and damages the mitochondria more.
Yeah. I'm
Okay.
not sure its role. The mechanisms, basically, like everybody who already has an idea of how things work are trying to implicate their particular models and apply it to ketamine. So I didn't go into much of it because it's kind of maddening. It's like the NMDA people are saying NMDA is responsible for it. mTOR researchers are saying mTOR is somehow implicated. BDNF, all kinds of different things.
I mean, I'm not familiar with this either, but I think ketamine has actually anti-inflammatory effects, from what I recall.
Yeah.
I mean, it's not an area of my expertise either.
But yeah, what do you know about it? You
I'm a
probably know more than
nutritional
I do about
biochemist,
mTOR.
and I have an interest in mitochondrial research because there's so many toxins in the environment that are damaging and killing mitochondria.
And mTOR has been implicated in
And
being directly toxic to
autistic
mitochondria.
children, I've treated over 2,000 of those in the last 20 years, and they're known to have mitochondrial damage. So it's just part of what I have to pay attention to. Did
Sure.
either of you find have any comparisons with methylfolate for depression?
That's a very interesting area that is really getting even more interesting. I think in 2007, there was an article called The Homocysteine Hypothesis of Depression, written by somebody from Johns Hopkins. And I think the most solid piece of evidence is that there's a gene in the so-called methylation cycle, or an enzyme called, well, you know this, you can say more of that, but called MTHFR, that comes in a couple of alleles that are much less sensitive to folate. And that I had a patient last week that was homozyggotic for the C677T and the A1298C.
All four?
Yeah, so he had processing folate about 10% of the normal population rate. And then we've been sometimes getting genetic studies of using 23andMe to look at various genes throughout the methylation pathway, and sometimes it's particularly when it's combined with MTR and MTRR, it seems to be particularly difficult. But I'm still trying to sort out what is what and how to approach it. I think is still a matter of a lot of debate and discussion, and very little.
There is still a lot.
Yeah.
Although there was a book published by William Walsh in 2012. It's a history of 30,000 tests, including those by Carl Pfeiffer, who was a famous psychiatrist, and it talks about all the research they did and how there were different biotypes of schizophrenics and the depressives.
Yeah.
They kind of overlapped as far as the causes were concerned, but in one case they were saying some people didn't have enough folate or methylfolate, others did not have enough methylation.
Right.
Yeah, I found it, as a scientist, kind of confusing
Yeah.
because it wasn't really clear, because none of the 3 generations of people who worked on this, they had all alternative ideas about what it was, and they were measuring histamine levels and so forth. And it got very confusing, but it's a fascinating book. And I do
Yeah.
treat schizophrenics and autistic kids and depressives and seizure patients and the hard ones.
Well, I was looking at this literature just recently, and there was an article by E.H. Reynolds, I think it was, from more than 20 years ago, showing that he identified a subgroup of patients who had elevated homocysteine levels and reduced folate levels peripherally and in their cerebrospinal fluid, and then they had lower levels of monoamine metabolites in their cerebrospinal fluid. So he was talking about it years ago. Recently there was an article in support of something called Enlight. It's a nutritional supplement that's been supposedly specially formulated to deal with people who have problems with the methylation cycle. And then there's this other interesting literature on cerebral folate deficiency, that there are some people that don't transport folate well
Into the brain, across the
brain.
blood-brain barrier.
Yeah, in the past this was mostly thought to be associated with very severely ill children, but there are some hints that perhaps in a less severe form it may be seen in other normal humans. There was actually a study in autistic children at the University of Arkansas showing that about 75% of children with autism had lower levels of cerebrospinal fluid, folate, and seemed to improve with folinic acid. I think I saw an article that didn't replicate this, so I don't know what the
Well, it
stories
depends on
are.
whether they're using a methylfolate, which works in the cells, and the folinic acid, which is actually, it's called formal folate as well, works in the mitochondria. The B12 has similar things. It has 2 forms, the active form, because humans, no one really can use vitamins in food form. They all have to be metabolized to active forms.
I believe the Enlight
Has 3 forms of folate.
Yeah, 3 forms of folate. 3 forms of folate.
Yes, sir.
2 questions. First of all, have you had any experience with using ketamine to alleviate chronic pain due to neuropathy? That's the
Yes.
first one. And is it effective?
It does seem to be very helpful, yeah. And particularly with complex regional pain syndrome, the ketamine coma therapy, when you put people to sleep with a very high dose of ketamine for 5 to 7 days, are reporting long-standing remission with this, like 8 years in one case with an otherwise untreatable condition. It's virtually impossible to get that here locally. Lower dose ketamine can be very helpful. One of my patients went down and visited with Dr. Kirkpatrick and had been basically curled up in a ball for a year prior to seeing that, and I think it cost her $20,000 or so to do it. But he does 4-day, 8-hour ketamine infusion sessions, and that got her back some functional recovery. And then I can't do the high dose that anesthesiologists do, but I treat her weekly, and she gets, she says it's the most effective treatment she has for pain. And several patients I've treated, even with low-dose ketamine, have reported that if they have a patch of, say, this big on their leg of CRPS or something like that, that it gradually shrink at a given time, so that I wonder if even a low dose therapy can be helpful. Sometimes I have it compounded as a cream and use it along with lidocaine and gabapentin and amitriptyline, and that can be helpful.
Decreasing in the size involved and the intensity is pretty common. Even in people who maybe are being treated for depression and have concomitant pain syndrome, it's pretty common that they're, require less opiates, for example, or less pain management in general.
And the second question is, why is everybody kind of starting as this baseline with the 0.5 milligrams? You said that you had a personal experience, I think, at 1.5, which seems like that type of experience you had would be very helpful for depression.
Yeah, but not everybody's ready to tug on God's beard right off the bat.
Right.
Particularly, I think if patients, I have had, just a few people. I had one patient who had very severe PTSD involving trauma that occurred while she was prone. We treated her in the hospital with IV ketamine, and it's partly related to her being prone on a stretcher, but it produced a severe flashback with freezing and a very, very low dose of ketamine, below 0.5 milligrams. As we gradually, incrementally went up on the dose, the flashbacks became less and less and less, and she didn't have freezing anymore. Now she gets it periodically. Does a reasonable job of helping to control her flashbacks and nightmares. Helps keep it at bay. But most of the time, if you are gentle with people and take your time, I've only seen a few times that it's made flashbacks worse. On the other hand, I've had several patients admitted to the hospital following colonoscopy, triggering a worsening of their PTSD. Which makes sense.
And similar to the use of IV in general, it's sort of an appendage of that this is the first study used, and so in order to be able to compile as much data as cleanly as possible, they've kept the majority of the larger studies have kept the exact same regimen, with no evidence necessarily that is optimal or that other doses wouldn't work or wouldn't be effective. There's some small studies that have been done, but they're not high quality information that have shown different doses are helpful also. With the alternate routes of administration, it's particularly important to take into account bioavailability. If you put a drug directly into the vein, it's 100% available. Intramuscularly, you have to, typically it's not accounted for, but because it's about 95-97% bioavailability, and it kind of keeps going down from there. Intranasals 45 to 50% bioavailable, orals like 20% bioavailable, hopefully. But yeah.
With the 0.5 kilogram, 0.5 milligrams per kilogram protocol, what do patients typically report as it's coming out?
As far as the subjective effects?
Yeah.
Typically, people, there is an ability, I think, as with most drugs that alter your perception, to fend off to some degree the subjective experiences. So I think it really has to do, this I think ties a lot into the attachment motif, and can even be used kind of as a measure of where you are in establishing a secure attachment with between the therapist and the patient, and sort of how intense of an experience they'll have with a similar dose. Because to some degree, if you're insecure and fearful of what is happening in basically a strange situation, then people will tend to ground themselves, open their eyes, sort of grab things, reorient themselves to the non-ketamine sort of world.
Typically, what do people say? What's an example of what's typical of what someone is saying?
It's hard to say, I think. I don't know if there is anything that's a typical experience that people have. People can have an ego dissolution experience, like Dr. Early described, where people have an experience of a loss of sense of self, dissolving of the ego. Other people have just sort of a visionary experience. I think setting has a lot to do with that, where they are, their sense of security, as well as, the setting, what kind of music is being playing, that kind of.
You said Dr. Early, you divided it into three doses.
Two or three doses.
So like, what's the range or whatever, what frequency of the doses? And
Well, I mean,
why do you do that?
well, at least certainly for the first session, I'd rather introduce it gradually to it, so that if you give like a third or a half of the ketamine, and it's just kind of a slightly sedated effect, like like you've had a couple of martinis or something like that. In the lower dose range, I mean, people tell me that usually things seem brighter. They occasionally they have visual hallucinations, but usually not. When you go to the higher dose range, you see near-death experiences. And they have one patient remember a previous life. All these kind of like visionary type things that are typical of psychedelics.
Transpersonal experience, like becoming objects, becoming spaces, things like that.
Is the therapist commonly interacting with the patient during the ketamine experience or afterwards, as far as how is therapy taking place?
Sure. Typically, it would occur after, or maybe even on a separate day. But there is some like word finding difficulty that can be frustrating for people when they're first emerging. So you definitely have to be careful with, not pushing too hard to get in there, but sort of creating a space where people can talk about, if they wish, anything, is pretty important. So yeah, it would be afterwards. During, it's sort of a lost cause.
As far as for the suicide patient that you treated, did you need informed consent, or how do you give such a thing to help a patient like that?
I'm sorry for.
For like informed consent, I mean, do you have to? They should know what they're getting, but how can you?
So we have a consent form, and we go through, all of the.
Prior, okay, so somebody in great distress, you're still going to have to try to explain all what this is, and then have them say, okay, I get it, right, when sign things?
Yeah, I'd rather see a patient a couple times to bond with them before I do a treatment. Rarely I see people that say they're coming in from a distance away that they really want to try to get a treatment when they're seen. So, nothing is written in stone. You try to be attentive to what the patient needs, and sometimes I'll do that. But I'd rather have the patient have some degree of security and understanding of what's going on. Plus, I'd much rather have them have a good psychotherapist that they're seeing and they're working with to already in place before the first session, so we can kind of coordinate that.
Can you guys talk a little bit about the contraindications? Because you mentioned working with an 89-year-old person, bipolar patients, people kind of a higher risk you might think of. So what are some of the contraindications? I imagine schizophrenia would be one. Are there any, or is it a contraindication?
So far it has been, in history of psychosis has been a contraindication in the studies that have been done.
Mm-hmm.
But recently, actually in the past year, part of the update of our review, there was a study that was done where they gave, I think it was 6 to 8 people involved in the study, and 3 of them had a history of a psychotic episode, or even were having an acute psychotic episode, and they were receiving ketamine on the inpatient psychiatric unit. And I want to say two of the 3, if not all 3, actually had a resolution of their psychotic symptoms and improvement in depression.
Wow. So,
I wouldn't say it's a contraindication. There isn't an established list, unfortunately. That's one of the downfalls of not having these studies appropriately done. But it's something that I would say ought to be a contraindication, especially in the outpatient setting. If something's acutely psychotic and depressed, they should be in the hospital anyway, for sure.
There's a Japanese study, interestingly enough. I mean, in the 80s, they did some ketamine challenge studies in schizophrenia, showing that ketamine in low dose would reliably improve or bring out hallucinations and positive symptoms. And there was a discussion about this. It was but there was a Japanese study where they took patients who had schizophrenia, who presented with something like a broken arm or broken leg, and they compared a group of them that had ketamine anesthesia, a group that had other anesthetic agents not involving ketamine. And surprisingly, about I followed them up for 2 months, and the group that had ketamine had a lower rate of hospitalization for psychosis. So it's kind of intriguing to make me wonder whether or not, in the short run, it might provoke positive psychotic symptoms, but in the long run, it might even have some positive benefits. I don't know. I've personally treated patients with psychotic mood disorders and seen that improve.
Like current substance abuse issues is obviously something I would consider a contraindication. Out of control, blood pressure, just things not being controlled in general. I like to have any medical issues stabilized.
When you say current chemical dependency issues,
Yeah.
how do you mean that?
Somebody who has a loss of control of use and using substances in the face of consequences.
Yet didn't you just present data suggesting that it's an indication for exactly that?
Well, it can be helpful, but for example, I had a patient that I was treating who got some benefit from ketamine, but then began overusing intranasal ketamine, and so I ended up having to take him off of that. I think it's an unanswered question. And Dr. Pauly, who's in our clinic, we've been talking about how to approach patients that have substance abuse issues that are getting treated with ketamine safely, and how to monitor them to make sure that they're not using other drugs, and how to, because I think they can potentially benefit from it. But it's an area I don't really feel. I mean, I've done it more from the standpoint of treating the mood and anxiety disorders that go along with substance abuse than somebody that was in recovery. If somebody was actively drinking or using other drugs, I would insist on them being in recovery, at least making an attempt at recovery before I would treat them.
And your experience with route of administration, aside from the bioavailability issue, the duration of action variable, does that inform your perspective on intramuscular versus IV administration?
For me, and I think both of us have kind of found that the IM works just as well as the IV. I mean, just in my comparison of having done an IV at Cottage and compared to IM, I think the results roughly seem to me to be comparable. Now, with oral dosing, I usually tell people, of course, you have to tell people not to drive after taking oral ketamine. I usually give it to them at nighttime as a lozenge, and then that kind of gets past that, but they don't drive until the next day. And then I tell them to lock up the ketamine, keep it in a book safe or something like that, and have sort of some guidelines on if we do home ketamine, how we try to make it safe and monitor it.
Do you feel like that if this does get more popular, that there's a risk of a legal backlash of some sort, especially if there's one or two, adverse cases or something like that, where there could be some kind of negative, backlash or not? Do you feel like it's?
Yeah.
Sure.
Absolutely. Yeah.
I mean, I think, and this is kind of a dilemma, is that eventually, if this is used in hundreds and thousands of people, somebody will have an MI, or something will happen during a ketamine session. If this happens with a psychiatrist doing it, there's probably going to be a different response than if the same thing happens with an anesthesiologist doing it. And the largest study of ketamine safety, the article by Strayer that looked at 70,000 published cases of ketamine, they found that there was one case of fatality that could be attributed to ketamine in a patient that otherwise had renal failure and a number of other problems. So it seems to be really pretty safe drug. And I have yet to meet an anesthesiologist that's seen someone have a severe adverse reaction to it as a sole anesthetic therapy. In children, sometimes you have to worry about laryngospasm, and I've never seen that or met anybody that has seen that. But particularly if a child comes in the emergency room and they've got a sore throat, and their upper airway is irritated to begin with, I think there's a risk of that.
Did something like that happen in Russia?
No, I think the problem was that people started abusing it. Russia is a culture where they use crocodile and all kinds of things to alter the pain of living, and just got too widely abused.
What is the APA's position right now?
they're coming up with a position paper, and I can only hope that they don't ruin it, you know, because I can just see that they would come out with a policy that requires, you know, 2 hospital lawyers and, you know, $5,000 of monitoring and something that would just totally make it a different treatment and make it unavailable for people.
So you mentioned Roland Griffith's work with psilocybin and mystical experience and so forth. So, and you also mentioned mystical-like experiences with ketamine. So has something been similar been done with ketamine to see what doses reliably can trigger a mystical effect, and studies that looked at whether or not the mystical effect was the curative factor in certain ailments?
To my knowledge, it hasn't been looked at directly, though ketamine's ability to induce the mystical experience, I believe, has been looked at by Ballenbinder. Not totally sure exactly what he came up with.
Yeah, Dr. Krupitsky has some of his work. He talks about, you know, dose range and what type of symptoms you get at different dose ranges, but I don't know that he's talked about. I think there was one article, wasn't there, that Ballenbinder's article that suggested that more dissociative effect was associated with more benefit. On the other hand, I have seen people that were not getting a response to a typical you know, lower dose of ketamine that coincidentally had surgery, and I called up and asked the surgeon to give them, in addition to everything else, a good anesthetic dose of ketamine, and they came out of the surgery better. So that I don't think that you have to be conscious to get antidepressant.
One last question. Just earlier tonight, I was watching YouTube. Someone was talking about using transcranial magnetic stimulation in addition to that, and said it got some remarkable effects. Like some people have been depression-free for up to 3 years. Have you heard anything about that, or are you familiar with that?
The TMS is reported to give a more prolonged benefit than, say, electroconvulsive therapy, where you almost always need to do maintenance therapy. I had one patient that was getting both ketamine and TMS, and there did seem to be some sort of synergistic effect. I don't know any data on that.
Yeah, we didn't include it in our review, but what I have seen, it hasn't been too compelling that it's got significant synergistic effects. Typically, my understanding is that recommendation is to sort of do one or the other, alternate, not effective.
Might there be any benefit for ataxia? There's various forms of ataxia, but do you know what ataxia is? Or
Yeah, spinocerebellar degeneration.
Might ketamine and all help ataxia in any way?
I have no idea. You know, I know that's I have a couple of patients with that, and it's a very difficult thing to treat. I think some of them use a version of coenzyme Q that seems to limit the damage, but there's really not much in terms of treatments available for any
Are
of
you
those
talking
conditions.
about ataxia due to an accident or just
No,
born that way?
Like a shot of Joseph's disease, the spinocerebellar ataxia.
Yeah.
Well, I have seen children born with ataxia. You sometimes see it in autism. But there are animal models where it's due to a manganese deficiency because that controls the amount of cartilage that's produced.
Oh, that's interesting. Manganese is neurotoxic, and you can get Parkinson's from manganese.
But manganese is necessary to convert glutamate into GABA.
Interesting.
Well, I think that's probably all the time we have. Just one last question, if I can find it here. Oh, the suicidality. So, showed some impressive findings of, depression and suicidality go down, but then there's over a matter of weeks, how many weeks comes back without. So I'm just wondering if there's is there an increase in suicidality that comes with those, because I can imagine it's very distressing to get rid of it for a few weeks and then have it come back. So I'm just wondering if there's an increased.
I would say it goes the other way. I mean, I don't know what you think, but.
Well, first I want to just make sure that it's understood that, like, that's in studies where they decided to stop as, like, that's in the protocol. They've stopped treatment at that point for the purpose of the study and following to see how long the benefits could be extended after stopping. So there have been case reports where people continued ketamine indefinitely, more or less, and varying the frequency based on how they're doing, using best clinical judgment without a return of their symptoms. So hopefully it won't be something that we have to worry about too often if it can be safely done to just continue ketamine at a minimum frequency but effective frequency. Return of depressive symptoms in general, when somebody has had some relief, I would expect would increase people's risk of suicidal ideation at least. But there hasn't been any evidence that I've seen that it's worsened.
I mean, I think, usually what I've seen is it's helpful, because patients may have been depressed for 5 or 10 years, and they suddenly get a glimpse of what the world looks like not being depressed. They realize that it's possible for them,
Yeah.
and
But they're not broken.
It's heartening, and there's someone on our email list who's doing ketamine bolus therapy in New York, that he was part of the original study with suicidality. And then, another thing too is that sometimes it can be helpful in sort of clarifying a diagnosis, because depression can look like a lot of other things, and people, when you clear the depression, they look a lot different, and you have a better sense of how the mood affects other aspects of behavior, anxiety, personality, and so forth and so on.
Cognitive functioning. Yeah, they actually, there was some concern about possible effects on cognitive functioning because in heavy users, again, you can't dice out heavy user population primarily because, or you can't dice out what ketamine is responsible for, because typically they're polysubstance users, people who use ketamine. There's very few people who use only ketamine. In that population, there have been a few neurocognitive deficits that have been shown with long-standing heavy use. But in the studies where they looked at that with the treatment for depression, they've shown actually improved neurocognitive functioning. I think they're not sure if that's something that ketamine is causing, or if it's more a release of depression that's caused sort of a return of their baseline higher functioning.
Well, thank you very much. It was wonderful.